Start with a question here. 63-year-old man presenting to the emergency room after evaluation of severe chest discomfort that awakes him from sleep. Pain gradually resolved after 5 minutes and recurred several minutes later. He's been unwell for the past few days. He's got a fever, he's tachycardic, normal heart sounds. He's got a normal CKMB. Does anyone still get a CKMB? This is an old case, obviously. His troponin is elevated at 15. He's got a white count of 11,000, and his SAID rate is up to 55. And he's got this ECG in the bottom corner, which I probably should have made bigger for you. But you're going to guess what this is because it's the pericardial disease talk. So with that story, which of the following is the next step for this guy? Should we get an MRI, start him on prednisone, start him on indomethacin, or get an angiogram? Indomethacin. Okay, we'll come back to that. Next question. In which of the following circumstances is pericardiocentesis recommended? Post-cardiac surgery with an effusion, normal heart rate and blood pressure, but some respiratory variation of Doppler flow velocities across the mitral and tricuspid valves, or a young patient with chest pain, moderate-sized effusion, and a widened mediastinum on chest x-ray, a moderate-sized effusion with normal Doppler flow velocities and normal blood pressure and a markedly elevated TSH, or a small, moderate-sized effusion in an asymptomatic breast cancer survivor 8 years after last evidence of disease. Okay. So we do not have guidelines for the management of pericardial disease by AHA and ACC. So the best document to kind of give you guidelines around management is this 2015 document from the European Society of Cardiology. And it's quite handy to have around. It's pretty practical, so I would encourage you to have a copy of that. So our first learning objective is going to be talking about the management of acute pericarditis. As you know, these are patients with chest pain, and you really need 2 or more of these features there. Classic chest pain, often positional or pleuritic, often associated with some other viral type syndrome in the days before that. Classic ECG with the diffuse ST elevation or PR depression. And effusion can be present in up to 60% of patients. And the friction rub, it's interesting. It can be there within 1 day and absent other times. It can be positional. And often I think people filter it out. They think they're hearing some scratching from the clothes or chest hair or whatever. And it's actually, it sounds like an extra cardiac sound because it is, but it sounds like something you just naturally filter out of your ears and try to ignore as you listen to the regular heart sounds. Let's see here. So it's felt to be viral. As I said, it's a clinical diagnosis. The ECG is super helpful, but the classic history is there. And troponin is very helpful because the pericardium and the myocardium sit next to each other. And if the myocardium is involved to a significant degree, that's going to change some management. So a troponin is helpful to know if there is a degree of myopericarditis. Now this is a summary slide I put together from how they recommend managing someone presenting to you with a syndrome of acute pericarditis. There's a series of risk factors there that if any of those features are present, you probably want to manage that patient in the hospital until they get pain-free and you've determined the overall etiology. But in the absence of any of those features, then you can start them on empiric therapy that we're going to talk about. See them as an outpatient or talk to them as an outpatient within a week or so, and if their symptoms are better, awesome. If not, the first thing to do is talk to them about their adherence to your empiric therapy that we'll talk about next, or look for another etiology for their chest pain syndrome that they're having. So this is just a nice way. Most patients can be managed completely as an outpatient and will respond to the therapies. Now, classically, we've been using non-steroidal anti-inflammatory drugs. Usually people get started on it for a week, and then this study, which is now 15 years old, looked at the benefit of adding colchicine for 3 months around the time of acute episode of pericarditis. And you can see patients treated with colchicine had a better event-free survival. So event-free is recurrent chest pain or survival. And then it's always important to point out that we really try to avoid using glucocorticoids as therapy because it will be effective initially, but it is associated with a high rate of relapse of pericarditis as you bring people down. But this was really the study that put colchicine at the forefront of being an adjunct therapy for managing patients with acute pericarditis. So this is really what you should be doing, is you should be choosing one from each of these 2 boxes as you're starting someone for management of acute pericarditis. You can use aspirin in high dose. And so if this is occurring after a myocardial infarction, say, you're going to want to use aspirin rather than one of the other ones. You can certainly use ibuprofen, and you can use indomethacin. There may be reasons why you pick amongst those for a given patient based on renal function, etc. You probably want to use gastric protection because we're going to put them on at least 2 weeks of therapy because you're going to want to taper that nonsteroidal after the first week to 10 days and not just stop at cold turkey. And then the colchicine, again, this is the European recommendation. They have a 0.5 dose. We have the 0.6 dose. They dose it based on body weight, but you want to have them on colchicine for 3 months. You can follow the patients based on their CRP. Most of the time, I don't think that's necessary for an initial episode of pericarditis, but if they have recurrent pericarditis, then you're going to want to follow the CRP to know that that inflammation is being suppressed. So one from each box. Recurrent pericarditis, again, is the recurrence of this in rapid succession. So again, the first line of therapy when they have a first recurrence is to go back on the nonsteroidal and colchicine, use the CRP to guide when it's time to taper and the speed of the taper. Rather than stopping it at 2 weeks, you're probably going to taper this over 4 weeks, and you're going to keep the colchicine on for an additional 3 months. So now a total of 6 months rather than the initial 3 months like you do for the initial episode. If that doesn't work, then you can go to triple therapy and add a steroid. You're going to still, and you have on steroid, nonsteroidal, and colchicine. You will take them off in that order and do so gradually. Look at this here. This is a long-term taper. It's over 6 months perhaps. And one of the key points to this in a practical management is when you get below, say, 20 or 15 milligrams of prednisone and you make a step down, they probably will have some recurrence of their chest pain. Talk to the patient about that. Help them expect that to happen, and don't react and go back up on the steroid right away. Tell them it's going to get better in 2 or 3 days. And if they can hang in there for 2 or 3 days, then you can get them down to the next dose and just gradually, gently bring them down on the steroids. But the thing that we get into the thing is reacting to, oh, my chest pain's back the day after I went down on my steroids, and then bumping the dose back up, and then you've got that person on a constant yo-yo with their steroids. If that doesn't work, then the immunomodulating agents have started to be used, IVIG, anakinra, and AZT. Again, slow tapers, one agent at a time, tapering down to the simplest of those, and you're probably going to use long-term colchicine as just suppressive as you get down to this type of patient. Pericardiectomy has been used, but remember that doesn't make inflammation in the chest go away. It's going to temporarily make inflammation in the chest to go up. And so these are patients who you're really stuck with. You have a long counseling session with them that they may still have pain in their chest. They may still have a chest pain syndrome. It's just not going to be the pericardium if you remove the whole thing. So not an ideal outcome for most patients. Now the idea of myopericarditis. If you have a patient and you've checked the troponin and it is elevated, then you need to get an MRI to see if there is extensive myocarditis involved, because that may change your management if it's a lot. You are likely to put that patient in the hospital and monitor them until their pain is gone. Obviously, if they are the right demographic or the chest pain has mixed features, you might consider a coronary angio in the face of an elevated troponin, hospitalize them. And if they are an athlete, a big-time exerciser, or in the military, the European guidelines suggest that they stay off active, high-intensity type stuff for 6 months since the onset of their syndrome. So the answer to that first question is, with the elevated troponin, was check an MRI on that person to see if they had extensive myocarditis. If you just have a little bit of lighting up of the myocardium right next to the pericardium, you don't have to be overly aggressive with that, but if they have extensive myocarditis, you're going to want to follow this patient more closely, probably do some serial echocardiography to make sure the EF isn't dropping over time with those types of patients. Now, we already asked this question, so I won't answer it again. Answers 1, 2, and 4 both got endorsement. I agree that pericardiocentesis is not needed in number 3 for sure, because of moderate pericardial effusion. You've got the etiology here. It probably has to do with the thyroid disease. No reason to go in there. Pericardial effusions cause symptoms mostly based on the rapidity with which they accumulate. A slowly accumulating pericardial effusion, like you can get with thyroid disease, usually the pericardium stretches nicely and doesn't compromise the cardiac chambers. But a rapidly accumulating effusion, say like an aortic dissection that dissects back into the pericardium, in addition to the dissection pain, is going to cause cardiac embarrassment from the extra pressure in the pericardium. Doppler, the phasic variations that we see with Doppler will occur in most cases before the patient feels symptoms. The Doppler is very sensitive to these findings. A brief summary of what we see on echocardiogram. Obviously, you see the fluid around the heart. You can see the RV being compressed in diastole when it should be fullest. You see the right atrial free wall kind of flapping in the wind when the pressures are equalizing between the RA pressure and the pleural pericardial space. The IVC is going to be thick, and then you can also get that abnormal pericardial motion. This is just a still frame of the short axis of the LV and RV. This RV should be plump, it should be full, and it's compressed down. This is what it looks like on M mode. Diastolic compression. Pericardiocentesis is indicated for patients who have a clinical syndrome of tamponade. So hypotension, tachycardia, low output, and they've got features of tamponade on the echocardiogram. Pericardiocentesis is required if you need it to make a diagnosis. Why does this patient have an effusion? That's another reason to do it. You definitely don't want to do it if you do think there's signs of aortic dissection, because if they are dissecting back into the pericardial space and you take blood out, you're just going to be draining their aorta as well, and that's not really a good thing to do. You do not need to do a pericardiocentesis just based on Doppler signs of subtle variation if the patient is clinically stable and you don't need the diagnosis. That isn't a reason for an emergency echo or an emergency pericardiocentesis in the middle of the night. You can take some time in those cases. The patient that really needs the pericardiocentesis from that question was the woman who had prior breast cancer. So someone with a prior cancer history who comes in with a totally out of the blue, no other indication for pericardial effusion, your first thought needs to be, is this recurrent cancer, that this represents a metastatic malignancy of some kind. The post-op patient who had normal hemodynamics doesn't necessarily need that drained. Obviously, the aortic dissection didn't need it, but the woman with the cancer is the one who really needed that fluid taken out and looked for cells to make sure she doesn't have recurrence of her breast cancer. Next, we're going to talk about distinguishing constrictive pericarditis from restrictive cardiomyopathy. Constrictive pericarditis presents with heart failure out of proportion to all the other imaging findings we have on the patient. So the most common symptom is heart failure, and it is right heart failure. It is elevated JVP, peripheral edema, big pulsatile liver. There's ascites. But it's right heart failure is the predominant symptom of these patients. In our experience at Mayo Clinic, most of the patients either have had prior cardiac operation or chest operation, totally idiopathic, or have had a prior history of pericarditis episodes with a mixture of other things. These are the neck veins of a patient who has constrictive pericarditis. You can see this person's sitting up, so super high JVP, but now also the collapsing neck veins. You can see how rapid those X and Y descents are there. Pretty classic findings of pericarditis. To make the diagnosis of pericarditis, echo, we need a chest X-ray. Often we get a CT scan to look for pericardial thickness, and you need those bottom ones only in select circumstances where you don't know what's going on after the first three. This is the chest X-ray lateral view of someone with pericarditis. You can see this is a calcified pericardium, classically talked about as being associated with tuberculous pericarditis. This is pericardial thickening in a patient with constriction. But note that we only see that 80% of the time. So that means that if everything else fits together and your CT scan says normal thickness pericardium, don't let one test throw you off the hunt. Everything else has to make sense. Now, we all were taught how to distinguish constriction from restriction in the cath lab. We were taught these classic criteria that filling pressures are high, that's dip and plateau, LV pressure trace, that the LV EDP is always higher than the RV EDP, that RV EDP is less than 1/3. So those are the classic criteria. But in terms of distinguishing constriction from restriction, they completely overlap each other. In a given patient, they don't help you. So what you really need to look for, which we've been focusing on for the last really decade, are those phasic hemodynamics that we see. So this happens because that thick pericardium essentially insulates the heart from the rest of the pressure changes that are going on in the thoracic cavity. So when you take a breath in and you drop your thoracic pressure, normally you would drop your right atrial and right ventricular pressure as well, and it wouldn't have much change. But now that pressure is staying high, and that's going to change these phasic things. So we're going to look for dissociation between the intrathoracic and intracardiac pressures, and the fact that the ventricles are competing for space within the pericardium. So if the RV is being favored, the LV is going to suffer. And this is illustrated by these classic movies that Dr. O made for us years ago. When you take a breath in, you get blood out of the abdomen into the chest. It fills the RV, which pushes the septum over and compromises filling of the LV. So during a breath in, all the flows on the right side of the heart are going to be enhanced. All the flows on the left side of the heart are going to be diminished. When you exhale, the opposite occurs. Now you retard filling of the right side of the heart. You force blood out of the pulmonary venous system into the left ventricle. So the left ventricle is favored and the right ventricle is compromised. So tricuspid Doppler should be going up and mitral Doppler going down, and they should be moving opposite of each other in the respiratory cycle. And so obviously all the echo machines now have onboard respirometers we can use, but those are the classic findings that we have for constriction. Here is that feature. So the mitral, with the breath in, the mitral E and A go down. With the breath out, mitral and E go up. The opposite occurs here in the tricuspid. Breath in, E is higher. Breath out, E is lower. The same things happen in the pulmonary venous signal and in the hepatic vein signal as well. One thing that's super helpful in determining the difference between pericardial disease and myocardial disease, so restrictive cardiomyopathy is a myocardial disease, it's going to have very low tissue Doppler velocities, because that's a myocardial thing. If it's pure constrictive pericarditis, the myocardium is fine, and it can only move longitudinally. So that means the relaxation of the heart doesn't go sideways, it only goes longitudinally. And so your tissue Doppler velocities are going to be enhanced. So you're going to have someone with heart failure signs and symptoms. They're going to have rapid E wave on their mitral inflow, and you would expect in a myocardial thing they'd have super low E prime, but these patients have a faster than normal E prime. And that's something that's very helpful in the echo lab in distinguishing constriction from restriction. A very fast E prime is shown here. If you are confused and you take the person to the cath lab because you can't make that distinction by echocardiography, what you want to see is LV and RV pressure traces simultaneously with each other. And what you see here is this person is taking a breath in, their LV pressure trace is getting smaller, and their RV pressure trace is getting bigger. That is ventricular interaction. LV getting smaller, RV getting bigger, constriction. In the patient with restriction, they move the same direction. LV is going down, RV is going down. That is concordance, not discordance. So again, same pressure traces, just highlighting them on the same slide. If the LV and RV pressures are moving in opposite directions in the cath lab, that's constriction. If they're moving together, that's restriction. So look for the variation on the mitral and tricuspid Doppler, and as well as the hepatic. Look for the E prime. Myocardial strain should be normal in constriction and markedly abnormal in restriction. The BNP is not usually elevated in constriction, and the LA is often not markedly enlarged either because it's trapped in that same space too. Surgery is the treatment for chronic pericardial constriction. The one time that we do use steroids is in the early postoperative period when they have effusive constrictive pericarditis. A course of steroids tapered gradually postoperatively can be very effective in treating that and hopefully preventing long-term constriction in those patients. So think of constriction when there's right heart failure out of proportion to other myocardial and valve findings. Think of constriction if the patient's had breast cancer or Hodgkin's in the past because of the radiation therapy that was delivered causes a bad constrictive pericarditis. And if they've had prior cardiac surgery, constriction is a possibility. Last, we'll talk about some pericardial cysts. So this is a chest x-ray of someone with a big pericardial cyst here. It's right here on this MRI, anterior to the RV, and here's another one out here. Pericardial cysts are rare, 1 in 100,000. You diagnose them usually with tomographic images. You can see them with echocardiography. You mostly don't have to do anything with them because they mostly aren't causing any compromise. But if they are in a position where they're, say, compromising RV filling, then you would have to resect it. Pericardial malignancies are rare as a primary malignancy, so if you do get a pericardial effusion, it's more likely malignant. And so again, in a patient with a prior history of cancer and a new effusion, think about the cancer as the first explanation for that. You treat symptomatically, use nonsteroidals for pericardial pain. And so to wrap up, pearls on pericardial disease, know the acute pericarditis ECG. You're going to use nonsteroidals and colchicine tapered for acute pericarditis. TAP effusions for clinical tamponade or a need to make a diagnosis and be able to recognize the hemodynamics of constrictive pericarditis. Thank you.